And do you know the distribution of, maybe you don't, I can ask the department, but the distribution of those two reports? I have to say I don't recall ever receiving them. I don't know if they're posted anywhere for public review.
We'd have to defer to the department, Senator.
We'll ask the department. And then actually, you did mention that there was that of your recommendations, there was one recommendation the department did not agree with. I do have it here. If I can read it here, or I can ask you what it is. But I'll just read it since I have it in front of me. To ensure that it meets the requirements of the new state law and that its performance measures are accurate, the recommendation of the auditor was the healthcare service should do the following: establish the provider-to-beneficiary ratio statewide and by county as performance measures designed to evaluate access and availability of dental services. Include this measure in October 2015 report to the legislature. And it says it disagrees. And again, maybe this is going to be a question for the department as to why that is such a difficult thing to do. But I don't know if you have any thoughts about that. I mean, clearly you had an opportunity to do that in your own report. Was that something terribly onerous or challenging?
All we know is what the department told us in the response about what its point of view is. So I think it's an appropriate question to ask to the department as well. What the department mentioned to us was, because it wasn't specifically mentioned as one of the performance measures listed in that particular section of the Welfare Institutions Code, it didn't feel that it wanted to do that. So our response was, well, the way that the law is worded is shall include but not be limited to the following measures. So there was an opportunity there for the department to include that. As another point, under the AB 97 monitoring with the 3 dental measures that I mentioned earlier, one of those measures is, and if I may, the number of child beneficiaries divided by the number of active dental providers, with the results stratified by factors as the county in which the beneficiaries reside. Sounds an awful lot like the ratio that we're asking them to include as part of it, when that's one of the ratios that they've been asked to provide, or that they agreed to provide as part of the AB 97 monitoring.
So apparently they don't want to do something that's already in state law again. Okay. Thank you.
Senator Hernandez.
Yeah, I know Senator Roth asked you the question with regard to reimbursement rates, what would be appropriate to address the problem, and you didn't have an answer, and I don't know if you do for this question, but can you tell me about, number one, distribution and capacity of the number of providers, and if we were to increase rates, if there was a proper distribution of providers, would they still be able to meet the demand? Because I seem like a lot of the dental providers are pretty busy as it is, and how would we fill that void, other than just making appointment times longer for all patients as a whole? So I don't know if you can answer that at all. Then I have a follow-up question on the procedures that were given to the individuals who are deceased. I don't know if you can answer that, the first part.
Okay, in terms of distribution, I'm sorry, I don't have a graphic up here on the screen that I can share with you. In our report in Appendix A, we have tables A5 and A6, where we actually break out for 3 years what the number of child beneficiaries are for each of California's 58 counties. We also include the number of active dental providers, and we calculate the ratio. So therefore, for Table A5, it's on page 65. It starts on page 65 and rolls over to the next page. That's where we talk about the number of active providers. As I said earlier, we talked about providers in terms of both those being active, kind of a looking backwards point of view, and we talked about those willing to take new Medi-Cal patients, which I look at as a looking forward point of view. If you look at Table A6, which is over on page 67, that's where we calculate, again, for each of the 58 counties, what the number of child beneficiaries are for each county, and what the number of generalist dental services offices and providers who are willing to accept new Medi-Cal patients. And again, there's the ratio. So we do, in terms of distribution, provide it, the detail. We drew no specific conclusions about that, though, in our report.
Yeah, because just looking at this, whether it's page 65, A5, or even 67, there's a lot of zeros in a lot of these counties. And so even if we were to increase the rates, I don't know how that's going to solve the problem unless we do like mobile dental clinics or vans or whatever. So, I mean, that's why I asked the question, because I know rates are important, but without somebody to actually see these patients, what good is it to have you double or triple the rates? So I have a question with regard to the services are provided to individuals that have deceased. Is this a percentage of fraud that's out in the just overall community as a whole? And I mean, obviously, you're not going to provide a service to those individuals.
Well, Senator, it's certainly a concern. The reason we've done this analysis, it's our information technology auditors assist audit teams, and we always do this type of analysis in an audit like this. And unfortunately, we found this issue, as Mr. Carlson indicated, in our August 2014 report when we were looking at drug Medi-Cal, and then with this report, and we're simply doing a match. I don't know exactly what the individual services that were provided to those purportedly deceased beneficiaries, but it was really a matching of points in time where a Social Security number and our IT folks were able to do that analysis. It could be fraud. We can't for certain indicate that it's a fraudulent activity, but we think it's something that the Department of Healthcare Services should do on a regular basis, and then when they identify those, and in this case 153 beneficiaries, then they do additional analysis to determine whether there's an error in the database. Is there an error with the Social Security number, or is this a fraudulent provider? Is it fraudulent activity that's occurring? But at the very minimum, we believe they should do that analysis so that they have the information where they could do additional review and determine whether or not there is fraud occurring in the program.
Okay, perfect. Thank you. Thank you very much. That's all.
Member Waldron.
Thank you, Mr. Chair. Just quickly on the data regarding the reimbursement rates that you did the analysis on the selected states, I noticed that Washington is broken out. It has children up to age 5 and then an overall. Is that because they do a different reimbursement rate for younger, or?
Correct. They have a different reimbursement rates for children age 0 to 5, and then they have a regular, if you will, rate for others.
Mm-hmm. Have you seen a correlation between more children in that age group actually seeing a dentist versus others where it's not delineated separately as a different?
As part of this audit, we didn't go into that level of detail with in depth with the 3 states that we looked at. When we were looking at the overall study where they identified those with high utilization rates, these 3 states popped up, and we started exploring why. What is it that's driving their high utilization rates? And after talking with the individuals there and taking a look at their reimbursement rates, that's what led us to develop this particular graphic.
And as far as now that we've moved away from Healthy Families, when we look back at that program, I wasn't in the legislature at the time, how were the utilization rates for young people? Any different under Healthy Families? Was there more access?
Yeah, I'm not sure I can answer that question. Although we were asked to include the Healthy Families program as part of our audit because it was on its way out at the time of our field work, basically what we did is we went in, we gathered some general information about what their utilization rates were, what their provider participation rates were, and we included that as Appendix B in the audit report. But we weren't doing, because it was on its way out, we weren't doing any more in-depth analysis other than providing some general information.
Okay, because the reason I ask those questions is, as we meet and try to delve into the data, looking at what the analysis has shown, then we need to be able to take that and move forward. And I'm just wondering, we may need to look at Washington. They're doing a different rate for children up to age 5. Maybe that's a benefit. Maybe we could look at something like that. How did Healthy Families, was there some good to that, some that wasn't? And try to create an overall plan that will work going forward as well. Thank you.
Member Sajian.
Thank you, Mr. Chair. Having been involved with local government as a member of County Board of Supervisors, we work very closely with the First 5 Commission. They did a great job. They work with community health clinics, offered mobile dental services, and our numbers went from 500 children on a waiting list to almost 0. Some of those kids had tooth decay that looked like they come from third world countries. But the bottom line is, and maybe Dr. Wood will enlighten on, is the number of years it takes you to become a dentist, then have your practice and pay all those expenses and the insurances. And by the time you get reimbursed, it's like working at minimum wage. And I think we can beat around the bushes all day unless we find a way to increase that reimbursement. We're not going to encourage more dentists to come and work in our territories, period.
Member Mainshine.
Thank you very much, Mr. Chairman. I want to go back to a little bit, a point that was raised earlier about the annual reviews. And my understanding is there over the last 15 years, even though it's been required to do it every year, it's been done twice. So what are the repercussions of that? I mean,
Well, the most important repercussion is the Department of Health Care Services doesn't have the information it needs to make good decisions and to bring information to the administration or to the legislature with respect to reimbursement rates, whether or not they're too low or whether or not what the impact would be potentially of increasing the rates to try to get more providers. So as far as repercussions beyond that, that's...
And I appreciate that part. But I guess it's probably somewhat poorly worded question, but what are the repercussions to the department for not doing the report? I mean, it's required, I assume, by state law, right?
Right, go ahead.
Yeah. To my knowledge, there's nothing in state law that provides a penalty to the Department of Health Care Services for not implementing that provision of law.
So this is kind of an optional choice?
Well, I wouldn't call it optional because I believe the law says it shall do it, and my understanding is shall is mandatory.
It shall do it, but if you don't do it, that's okay too. Well, I obviously that, I think that's a pretty good idea that needs to change. The reimbursement rates are obviously a critical issue. These access rates. Access issues that Senator Hernandez and others have brought up are critically important as well. But we have the most transformative time probably in healthcare law, going on right now, and it is absolutely essential that there be this data there, because otherwise, we have all this legislation that comes through that is somewhat. That is going on, maybe stories or incidental things that have happened maybe in one of our districts, but without some sort of comprehensive data. In my prior life in working with the homeless, what we were able to do in San Diego, I think, was significant, not just because we actually did something for the homeless, but we had we created a very robust data collection. So in San Diego and in other places, they could actually point to real data, not just something that, we see some homeless people over here, or we know homelessness is bad. We had something that we could show comprehensive across categories, how often they were visiting the ER, how often they were having law enforcement interaction. All of this was data. So here, when you have a shall do an annual report that you do twice in 15 years, you're just not going to, basically enough said on that. It seems absurd, really, but thank you.
Thank you very much. We have Member Woods and then Chairman Bonta, and then we're going to transition after that.
Thank you very much. Just a couple comments, actually, going back to Dr. Hernandez's question about if you just increase rates, is that going to solve the problem? And there is definitely a maldistribution of dentists. I don't think there's any question about that. But there are dentists in rural communities and in underserved areas that are not rural that are willing to do this treatment. I don't think it's an unreasonable burden to ask that you, as a provider, providing a service for fragile, low-income people, that you at least get the benefit of your cost associated with that. It used to drive my wife absolutely nuts that on a yearly basis, and we tracked this, that gave away about $20,000 worth a year of care directly. And a lot of it times a lot of times these were Medi-Cal beneficiaries that I chose not to bill because I found the system so difficult to deal with. I believe there are providers in counties, and the ability to recoup at least their costs would be a benefit for people to be able to do this. When it actually costs you out of your own practice to deliver the care, it's not much of an incentive to be able to serve the population. And you can only do that in a business model for so long 2044, you are no longer a business. You're no longer there to be able to take care of people. So also was brought up, the $70,000 maybe that was paid to deceased beneficiaries. That is, in the number of, that number as a ratio to the number of participants is 0.0000612%. You're talking about $70,000 out of a $350 million state portion. It's not even fairy dust. It's like one can of soda falling off the truck. It's really not going to notice that. So, but the question I have for you, and I guess what with an 86-page report, and you got like a page and a half response from DHCS, maybe 2 pages. They disagreed in some ways. My interpretation was that your report was not a reflection of the programmatic health of the program. Do you have any feeling about the programmatic health of the program based on your findings as an auditor?
Well, I think I would disagree with the department if they think the program is healthy. As we indicate in the report, we believe reimbursement rates are low. You compare it to other states and nationally, as Dale indicated. Utilization rates are incredibly low. I understand your perspective on the deceased beneficiaries, and that is just extremely low. My concern with respect to that, as the auditor, is if that's occurring in the Denti-Cal program and the drug Medi-Cal program, what other Medi-Cal programs is it occurring in? But with respect to your comment or question about their response, I mean, the department responding to us in December of 2014 is not the end of it. Obviously, oversight hearings like this will keep the heat on the department. In addition, as Mr. Carlson indicated, we received a 60-day response. Our 6-month response, interestingly, is due in June of 2015. Many of the recommendations the department intends to implement are July. What we can do and will do is ask the department to give us a response in either mid to late July, so we have that information as far as implementation. Have you accomplished implementation of those 15 recommendations that you assert in your response to us will be completed by July, so that we don't have to wait until the 1-year response in December. We have flexibility to do that, so we're happy to do that. And I think that follow-up process and continuing to provide whatever information the legislature needs from my office to hopefully get many of these, if not all of these recommendations implemented, will help to strengthen the health of the program.
Please, the chair. Just to follow up to Mr. Akajian, your comment about rural areas and dentists and debt and so on. It is very, very expensive education, and one of the challenges with the low reimbursement rates is that a lot of the population that we use to train our dental students go through dental schools, and so we've created this sort of a spiral effect. It's very difficult to run dental schools on those lower reimbursement rates, especially with the cutbacks, and then that adds an additional educational debt to students who then can't easily go out to communities to serve because they can't afford to be able to serve in these communities because they can't afford to lose any more money, and that's problematic as well. So I just thank you for your comment.
Chairman Bonta.
Thank you, Mr. Chair. Thank you for your presentation. Thank you for your audit report and for the important attention you're drawing to our Denti-Cal program in California. You have set forth 24 separate and distinct recommendations. And can you opine on which of those would make the biggest positive impact among them, so we can sort of prioritize among the different recommendations?
Sure. As we pointed out in the report, there's been a very clear line that has been drawn between increased rates of utilization tied to increasing the provider participation ratio tied to reimbursement rates. And I guess I would say, in my view, with the reimbursement rates, that has a very across-the-board kind of impact, or it can have a very across-the-board kind of impact. And it can affect rural counties and less populous counties in many of the same ways as it can the more populous, the more urbanized counties. There are things that have to be done, though. Let's not lose sight of what's going on in those less populous counties, because as you pointed out, or as has been pointed out, there are things that need to be done for those underserved counties where perhaps reimbursement rates is not the only thing that can be done. Senator Hernandez mentioned mobile vans. That's where, you're taking the supply to the demand, if you will, as opposed to setting up brick and mortar and waiting for the demand to come to you. There are things like that. There's a couple of recommendations that we make in Chapter 2 related to Delta Dental that talk about things like that, where we asked the Department of Healthcare Services to require Delta Dental to submit various plans. They require Delta Dental to come up with an outreach plan, an outreach program for getting into those underserved areas, for contracting with providers to get services such as through a mobile van into these underserved areas.
Thank you. That's very helpful. Another question, if I may, Mr. Chair. Among the different recommendations, you got a response from DHCS, and there was some discussion about timelines for implementation on the recommendations about which DHCS agreed were appropriate steps to take. In your view, can any of the recommendations presented in the audit be implemented faster than DHCS has indicated?
Mr. Bunta, Assemblymember Bunta, we believe that there are some recommendations. There are at least 2 recommendations that they indicate they will need until July of 2016. We think those recommendations could be implemented more quickly. Many of them, as I indicated in my response to Dr. Woods, many of them they're claiming they will implement 15 out of the 24 by July of this year. That's just a few months away, so we think that's somewhat reasonable, but we really do, as I reviewed the report again last evening, some of the recommendations to Delta Dental. We're paying Delta Dental $8 billion under this contract, and there are very specific provisions in that contract related to outreach, et cetera, and we think that the Department of Healthcare Services should really put a lot of pressure on Delta Dental to come through and hold true to many of those provisions. We believe they have not held true to at this point.
Thank you. Very helpful again. And just one final question. And I'll apologize in advance. It's a little self-serving. But what would be the anticipated impact of Assembly Bill 366, which I happen to author, which raises Medi-Cal reimbursement rates, and as well as Senate Bill 243, which my esteemed colleague in the Senate,
which I happen to be authoring,
Dr. Hernandez, is authoring. What would the impact of those 2 bills be on utilization rates for California's children in the Denti-Cal program?
Well, with all due respect, we don't opine on legislation, even though we think they're stellar bills. No, we actually clearly there are aspects of that legislation that deals with reimbursement rates, and clearly, based on the audit report that we've done, some of the studies we've looked at, there is a link between reimbursement rate and providers willing to participate in the program, which ultimately leads to more access for children and adults, which would increase utilization. So, any legislation that would address issues such as that, we think, would be beneficial to the state.
Thank you again for your important work on this issue.
Thank you very much. I think Member Waldron, did you have a question?
Well, I was going to follow up on the Delta Dental.
We're going to let this be the last one, then we're going to transition. So, Member Waldron.
With the Department of Healthcare Services to administer Denti-Cal, they have the agreement with Delta Dental, and part of that is they have apparently a toll-free number trying to outreach into the areas we were talking about. Has there been any statistics on how frequently the process has been utilized in recent years that Delta Dental has been using to make beneficiaries aware of the availability of the processes they've put into place?
What we did in this audit report is we were looking at things that the department and Delta were doing to help improve utilization. All we did for this is we noted that they had started this new toll-free 800 program, and that's where we stopped our work. We didn't go any further into any other analysis on that. We had a few other irons in the fire at the time. But I think that's a great question to ask the department.
Okay.
We have, the prerogative of the chair, we're going to allow Member Chu to make his brief comment.
Thank you. Just a brief question. As I read your recommendation, and first of all, thank you for this analysis, and I certainly associate myself with the comments by Dr. Wood as to, I think, our reaction to this and wanting to see changes. Most of the recommendations appear to be relatively procedural around establishing criteria and developing procedures and requiring various actors to provide plans. At the end of the day, CMS has said that we have a goal of trying to increase by 10% children who enrolled in Medicaid receiving dental services. And according to the Healthcare Services Acting Division Chief, they believe it's unrealistic to expect an increase in this 10%. Have you done an analysis? Let's assume every recommendation you have is adopted. How much money would it take to get us to where we're going to go? And I certainly want to support the chairman of our respective health committees. I support getting our Medicaid reimbursements rates back to where they are. But has that analysis been done? I mean, how can either you or the acting division chief of the healthcare services analyze whether we're going to make any headway in getting the numbers actually to increase?
We did not do that analysis as part of this audit report. Again, I would defer to the department. I think that is why the department needs to do some of the analysis that they're required to do statutorily, and then to proactively do some additional analysis to understand the correlation between, to the extent they can, an increase in reimbursement rates would ultimately result in X number of providers willing to participate in the program or willing to take on more beneficiaries and provide services to more individuals. But we don't have a specific answer to your question as far as how much money it would take.
Okay, and certainly I'll be asking the department to answer that question. How can they anticipate that even if they do all the things in this report, they won't be able to hit the 10% or the 10-point increase? Thank you, Mr. Chair.
Thank you. Let me confirm the timeline of some key actions that have us here today. Reimbursement rates are the primary driver for dental participation in this program. California has not increased its rates since 2001. The department did not determine whether the reimbursement rates were adequate for more than 10 years after 2001's increase. When the department received rates in early 2013, it determines that the rate is inadequate based on a slight increase in utilization. In September 2013, California reduced its rates by 10%. And here we are today with California reimbursement rates lower than national and regional averages. Furthermore, than half of the children in this program are not receiving dental care. Finally, providers' participation is too low, yet the department has to finalize its increase. Something is missing as it relates to this report. I think the comments that all of us have articulated here today are very concerning around this report. And I look forward to the department coming and answering some very poignant questions as we move forward. Thank you very much, Ms. Howe. We ask that you would take a seat in the audience. We want to bring up some stakeholders who will also provide some testimony to this committee. We would ask you to please join us at the table. John Blake, Ron Inch, Chief Dental Office for Western Dental, Jacob Virgil, Program Associate for the Children's Partnership,